Good afternoon.
Hello, how are you? Nice to see you.
How are you?
Hi. Good afternoon.
Hello.
Hello. Hello.
Hi, everyone.
Hello, Mariano. Nice to see you.
Hi.
Nice to see you all. How are you?
Good.
Well, and thank you.
Very hot. Hello, nice to see you.
Hi, hello everyone.
Hi, dear Ahmed.
Hi, how are you doing? Hi, Waleed.
Hello,
Hi.
Ahmed.
How are
Nice to
you?
see you.
All right, excellent, excellent.
Hello,
Hi.
Hi, Ferenc. How are you?
wonderful. Good to see you. It's been ages.
Yes.
Everybody is at home?
Yes,
Yes.
I'm about one of the homes. I'm in Florence at the moment, and I'm
Ah.
about to jump on a plane at 6 o'clock. So going back
And-
to the other home.
Yes.
Are you
perfect.
against the wall or are you lying on the floor?
I am against the wall.
Okay.
A wall you should know very well because you've been here.
Yeah, but all right.
Yeah, it's very hot here. It's about 38 degrees, and it's 22 in England. So
I guess nobody can speak about hot weather if you have somebody from Saudi Arabia.
yes.
But it's dry.
It-
It's dry there.
It's 45.
Oh my goodness. Okay. Well,
But I think every part is air conditioned, right? So
yes.
yeah. Okay, we'll get started at in like 5 minutes, and then hopefully we'll be in time. The format, as we've mentioned, is we'll have like some discussions on few points here, which I find really like interesting points, and no one knows really what to do. And then after that, we can move on to case presentations. All right?
Okay.
Okay.
Okay, excellent, excellent.
Ahmed, just a question. You think we
Sure.
will be done in 1 hour or one and hour?
I think the plan was 10:30 we finish. So, but of course, if you are pushed with time, like 10:30, so we'll like 1.5 hours. But we can try to. I mean, I think I tried to give ourselves like a bit of a space, but I mean, hopefully 1 hour, 15 minutes, we should be done.
Perfect. Thank you.
All right, excellent. And then with the cases, I mean, we can, if anyone is pushed with time, we can change the order. Otherwise, we'll go with the order in the flyer.
I would when I have a taxi coming at exactly at 5:30, so it's 4 o'clock now here.
Okay. No,
Yeah.
you're good. You're second to go.
Okay, thank you.
If we're going to go with the flyer arrangement, so
Yeah.
I think we're good ready to go. So it's
Okay.
Ferran and then Jim Paolo, yeah, and then Mariano, and then Saad, and then Radwan and Walid. Excellent.
I'm not seeing Dr. Radwan. Is he with us?
Oh,
Yeah.
I'm here.
Oh, Radwan.
Hi,
Oh, good to
morning,
see you. How
everyone,
are
or
you,
good
man?
evening.
Hi.
I'm doing well. I'm doing well.
Good to see you.
It's sunny here. I was hearing the comment about the heat and the temperature. I was like, yeah, it's really hot in Saudi.
I just want to make sure that everyone knows everyone. I mean, Dr. Jim Paologini is the president of the EVRS, and he practices in the UK and Italy. And Walid is a retina specialist and head of the VR surgery, and he practices in Tunisia. And Dr. Saad Wahib practices in Jeddah, and he's a vitreoretinal surgeon as well in Saudi Arabia. And Ferin Kun, of course, he's the trauma guy, and he practices in so many places. And I think now he's just citing Hungary and Germany just to make life easier for us. And Mariano is a vitreoretinal surgeon from Argentina, Cordoba. And then Radwan is a co-mate from here. He practices. He's a vitreoretinal surgeon, and he practices in Kansas. But he's originally from Saudi Arabia, and I think that's the connection with Dr. Saad Wahib, and myself. I practice here in Arkansas.
Nice to meet you all.
Same
Indeed.
here.
Nice to meet you.
All right, excellent. Okay, we're gonna go and start in 2 minutes.
Do you know how many participants we have?
Looks like 12 at the moment, but
Yes, I think there seems to be an overlap with another meeting with the Retina Work Congress.
Yes.
I think that's
Yes.
a bit of overlap, but I think we'll have it recorded, and I think that usually puts it really high when people have it recorded on the EVRS, and also I'll put it on the YouTube channel as well.
yeah.
So that's good. Farron, are you in where are you? Are you in Jacksonville or
No, actually, I'm in Birmingham.
are you in Birmingham,
Because
right?
my friend turned 80, so we
Mm.
had a birthday party last night. So I drove up here, which is only 800 kilometers.
Right.
Uh,
Right.
we drove up here Friday night, and as soon as the meeting ends, I'll drive back.
Okay.
Yeah, Farron I think he's a professional driver. He
Yes.
when he was very kind to visit me in Arkansas, he drove from Florida down to Arkansas, and I think he was like driving way from the East Coast, right? Was you were coming from the East Coast or something like this,
I
right?
can't remember, but it was a long drive. But after that, the first time from your place, I drove to California.
Oh, to California, West Coast, yes, right.
Yes,
Yeah,
that was a bit longer.
Yeah.
Do you know that they have invented airplanes?
Air what?
Oh wow.
I
Yeah.
know.
I
know
heard
you.
about it. Somebody told me about it.
Do they fly? Are they?
He's been flying a lot. I mean, more than he would like to remember, I think. Yeah.
7 million kilometers so far.
Yeah. Okay.
Yeah. All right, excellent. I think we can get started. So I think we'll go with order. So our first point of hello everyone. It's Ahmed Salam here from Arkansas, and I'm delighted and honored to moderate this session with from the European Vitreoretinal Society webinars. We had lots and lots of sessions during COVID, and then other sessions, and here we're resuming, and we hope that this will be a series. Will be moderated by several members in the future, and this is the start again. And I have here with me, honored to have Dr. Giampaolo Gini from Italy, UK, and Dr. Walid Zabiba from Tunisia, Dr. Mariano Ayres from Argentina, Dr. Saad Wahib from Saudi Arabia, and Dr. Ferenc Kuhn from Germany and Hungary, and last but not least, Dr. Radwan Ajlan from Kansas, USA. The first part will be a discussion about like something that what do we need to have in the future and some equivocal areas in retina, and then we move on to case presentations again on the same theme, which are gray areas in retina and things that we're not sure what to do. Okay, the first question for discussion would be so we have like new technology now and microscopes and light pipe, but what is the one thing, Dr. Gini, that you feel like we're missing in retina surgery now, and you would love to have something to fix that problem for you?
I think it always comes down to having a second hand. So someone helping us, because in the past we generally had somebody helping us. Then for economy reasons, we've come down to just one surgeon. We no longer have two surgeons in theater. And personally, I find that because we are trying to save on economy, we many times do not have the same access to the vitreous that we had in the past, when actually we had two surgeons working together. So that is something that I would like to address, obviously technologically, and I'm not sure how that can be done.
Interesting. Yes, that's true. Well, we need more manpower or an alternative. So Walid, anything in mind? Again, something that you feel like this is a problem that I would love fixed. For example, I had an ENT surgeon who made his legacy, ENT surgeon friend who had made his legacy thinking, what are the problems in thyroid? He's a thyroid gland surgeon. He found that actually two problems. One is the laryngeal nerve, they get cut, and the other are the parathyroid glands. So he invented instruments to detect both. And then surgery became safe, at least on his side. So I think something like this or along that side. What do you think we are lacking in retina surgery nowadays, or medicine?
For me, my main concern in VR is to be independent of my assistant. So because the mistake, it's easy to make a mistake by assistants, especially when we transfer skills to a young VR. It's very easy to do mistakes. So for me, my concern actually is to be independent. It's be more. I am more independent now with 3D system, with wide view system with no contact, like Resite or Oculus. So it's true, but not enough. I think we have to improve our thinking to do more and to avoid this assistant. It's my concern.
Right.
Okay.
Interesting. And Mariano, what do you feel? What do you think the one thing that you would like to like improve in terms of instruments or investigations or?
I was in a few years concerned about the you know, we have talked about this many times about retinal displacement that occurs in many RD cases. That I think it's a problem that was like underestimated many years ago, and I'm concerned in many patients in which the surgery seems perfect and we are very happy, but the patient is not. And we find in many of these cases some slight degrees of displacement. So I think for me, nowadays, this is a concern. I'm trying to be as precise as possible in these cases to avoid it.
Yeah, I share the same view. I was actually thinking of the same thing as well. And I think Barbara, in a discussion as well, was saying the same thing. If there's a way we can like even gauge retinal displacement intraoperatively to know that actually we're aligned nicely, that would be really great. So I mean, maybe like be able to do autofluorescence intraoperatively and align the blood vessels nicely. I think that would be fantastic. Saad, what do you feel?
Can I give you two thoughts instead of one?
Please.
From the surgical point of view, I think 3D surgery has really made a major, in my opinion, a major change to the way we do surgery. You agree with me that it's all about visualization, and I hope the technology will continue to evolve, because I feel I've been doing 3D surgery now for a while, and I think we do better, we see better, and the outcome is definitely better from my point of view. The other thing, I think we're very blessed in ophthalmology. There is a good connection between us and the pharmaceutical company, and I would love to see a pharmaceutical company come with a medication that we can inject in the eye that will prevent the development of something like diabetic retinopathy. I remember during my fellowship, Dr. Alan Bird from London came and gave us a lecture. This was more than 20 years ago. And he said something about working on this. Unfortunately, we don't have it yet, but I would love to have something like this before I retire. Thank you.
Yeah, that's very interesting. I remember Alan Bird from Morphos. That's fantastic. All right, and now we go to Farron.
Let me start by stating the obvious, that I'm older than the rest of you combined. And I started VR surgery very early, when both the equipment and the hand instruments were extremely primitive. And I had to learn doing things with that. So I'm actually fairly satisfied with where technology is today. I think both the hand instrument and the vitrectomy machines and our viewing systems are at the stage where we can make improvements here and there, but it's not going to be determining success anymore, which was not the case at the beginning. So I'm fine with a little refinement here and there. And I can't recall the last time when I had to say I can't do this because I don't have something tool-wise that would allow me to do that. But I want to go back to Gianpaolo's point about the assistant, because I also, the last time I had somebody actively assisting, not just being there to learn, but assisting, probably 25, 30 years ago, and not since. So I don't miss that part. What I do need, or would need, or would like to have, is when I go to a very difficult trauma case. So I'm not talking about, macular surgery or the vast majority of the indications that we do surgery for. But the really tough cases where you have to come up with an individualized solution for a particularly difficult case. At that point, to have somebody experienced sitting next to you who would have a different idea, who sees the whole thing from the outside, who may realize something that you, while you're doing detailed work, don't necessarily see and therefore think about. That would be very important for all of us.
Yes, no, that's true.
I always, and this is also very important for everybody who does VR surgery, which is the nurse. Because, and I repeat this everywhere I go and talk about such things, and I put it in all my books, that for the VR surgeon to have a nurse who is not just sitting there and following your commands, give me this, give me that, etc., but thinks with you. Obviously, she will not have as detailed an idea about the inside of the eye as a well-trained colleague would, but still, she is able to contribute a lot if you treat that person very well. So you are a team with at least with your operating nurse, and therefore you have to train her first and also have a wonderful personal relationship so that she is with you. That nurse will be able to give you, occasionally ideas that help in surgery.
Unmet, can I say something?
Yes, please, please.
I think, yes, I share a lot of what Ferenc has said, because despite what he says, I'm not in my prime either. So I've seen quite a few things. But going back to Saad, what Saad and Walid said, I think we're saying the same thing when we, in different ways. So the necessity of being able to see better what you do, because vitreoretinal surgery, like most surgery, is mostly about being able to see. When you see, you can do. When you can't see, you're guessing. And so that is the big difference. And the point of having somehow what I'm, obviously we have different experiences because each one of us has a different setting. I'm talking about settings in as you know, in the NHS, or most European countries which have a cut on their budgets, and therefore we only have one VR surgeon in the room. And the fact that that creates a problem when you are trying, nurses are not allowed, for example, to do certain things, like they cannot indent. And so if you are reaching for the periphery of the far periphery of the retina, and you want to do maneuvers there, you generally have to use a chandelier, because even a wide viewing system is not sufficient. So being able to compensate somehow for that would be, in my view, exceptionally good. Because again, if you don't do that, then many times you're not carrying out the procedure as you would like to, and as you did in the past when there were two surgeons actually cooperating with each other. I don't know if this makes sense. I think this is what we, the three of us, were trying to say, both Saad and Walid, when we were talking about being able to see better and also trusting your assistant if you have one. Yeah.
Yeah, no, I think this is does make a lot of sense. Okay, now Radwan, what do you feel?
Oh, well, I agree with everything said. Like I like the benefit of having a third hand there is very useful. For me, visualization is a key as well. So having something like, especially we have a lot of those trauma cases as a like as a tertiary referral center. So many times if I want to do fluid exchange, I wish there is somewhere where I don't really need to put a chandelier just to do the perfluorocarbon oil exchange, or still not going back and forth. So if there is a solution, we can just do it simultaneously on the machine. That would be a great point.
Absolutely.
Another point is just, hopefully, I really like endoscopic surgery. I find it really useful in my practice, but I wish there is a way, or there are better visualization, better camera. Now we have like I have a better camera on my cell phone, so hopefully someone will make it better for the machines. So those are my 2 cents.
Yeah, Khalid Sapti was working on this. We'll tell him. He was trying to make a new endoscope with better camera, with a 3D camera. So yeah, I think that's very interesting. For me, I was thinking like Mariano and Barbara initially as to how to like gauge traction and gauge displacement. But one thing also I thought of, which really makes my life difficult, and I had to close some eyes before, is bleeding, like bleeding during diabetic vitrectomy, and how to stop that. We know all the simple things, or the things we know are from raising the pressure and waiting and trying to get under air to compartmentalize, but sometimes it just remains bleeding. And I'm sure there'll be some substance we can put there to just stop the bleeding, and it will just stop the bleeding. I don't know if anyone knows of something like this. Maybe like I don't know, like a fibrin. I mean, I have not tried it. Did anyone try to put like a fibrin? Does it re-stop the bleeding? I don't feel it will stop like a lot of bleeding, but I think that's one thing for me.
To answer that question, or have my side of it, my personal answer. So I always use Avastin, because preoperatively, 2-3 days, not more, 2-3 days before a diabetic, which is more than just an edema, because that in those eyes, bleeding was always a horrible event, not only because of visualization, but also it clots very easily. And I remember eyes where I was trying to remove the clot and it tore the retina because it got so adherent to it. So I don't know if you do that or not, or
I do this routinely as well, but sometimes even with that, you can have bleeding.
Correct. There are a few cases where it doesn't work. Yes.
Does anyone have any experience with fibrin, fibrin, putting a fibrin there? Or?
I wish it did work. No, I haven't tried that. The only solution I can come up with is air, and then diathermy under air. But it's a poor solution. What you're suggesting is something which we wish we had. I haven't tried it. Did you?
I have not, but I've seen a video of someone, and I spoke with him, and he said if it's an only ooze, it may work. Otherwise, does not work. Sorry, Saad, you were going to say something.
I have a little tips here for in this case on bleeding, especially in retinopathy, diabetic detachment. I do a fluid air exchange, and when there is a small bleeding, I use viscoelastic on the bleeding. So it can help us to limitate the bleeding and continues our work. So I think it's not useful always, but I tried this several times. Sometimes it works, sometimes it's not. It doesn't work.
Yeah, depends how much bleeding you have.
Yes.
Yes.
Ahmed,
Yes,
and from the side of the tools, I don't know if for you it's easy to get it now, but in the era of the 20G gauge, there was an instrument that was fantastic. That was the aspirating diathermy, and
Yes.
now at least in 25G, it's very. I don't know if it does exist.
I don't think so.
Use it? Do you find it?
In which
Have you found the tool?
Which company does this kind of instruments?
I don't know.
Okay.
I remember that very well, Mariano. I don't think it's around anymore.
But it was a fantastic tool.
Yeah, for one thing, we now use only disposables, and that was not disposable. So
Yeah.
all these things have gone out of style, really. But it was good. It was aspirating and diathermy at the same time. Yes.
Yeah.
Can I just suggest something here? I strongly agree with the preoperative use of anti-VEGF. I think they do an important effect on bleeding, but I don't know, but it has been my personal experience. If I stopped using diathermy a while ago, because I have noticed these patients later on down the road, they develop atrophic holes in the site of diathermy. So I use laser instead. And sometimes if it's a real bad bleed, I use the tip of the cutter to apply gentle pressure, of course, after increasing the intraocular pressure. But it has been my personal experience, and I'd like to hear what you guys feel of using, I mean, in diabetics specifically, we tend to use, I used to use diathermy.
For example,
But I no longer use it because I have seen post-operatively down the road, these patients develop a atrophic hole exactly where I did the diathermy.
Those
So
I've seen. Sorry.
no,
Go ahead.
please.
So I've seen someone use the fibrin in fellowship training. I didn't try it myself. Apparently, I think there were like 2 types of fibrin that you can use like many people like have done their careers on that, but I think you can use it. On my personal, it depends where the bleeding is coming from. Is it retina? Yes, I may use like tamponade, or if it's really far away, it's a little bit like it would ooze for a minute or two and then it will stop. But if it's, especially if it's a choroidal bleeding, endocautery does not work for me at least. Laser is the key. That was a trick I really learned and I found it really useful.
Yeah, I think this is great. And I think it's a great point how to stop bleeding from everything, raising the bottle and also like pressing the down with the cutter and diathermy. But the problem with diathermy, as Saad has mentioned, it can cause the retina to be atrophic. Usually I would do like things that are standing proud rather than ones on the surface of the retina. I've tried laser, but it doesn't work. Even like when the ooze is very minimal, for some reason for me, it doesn't work. And I tried it several times and I gave up. And then you can go to air to compartmentalize the bleeding. And the question is, sometimes in DCR surgery, they use something to stabilize the clot. I'm just trying to remember the name of the medicine now. And I think it's
Tranexamic acid?
Yes, exactly. And I wonder really if there's an intravitreal use of it. Because they use it in DCR. My friends who do DCR, they actually use it and they swear by it. So I think that's the one thing I had in mind. So
They also use it when you're shaving.
when you're shaving,
When you're
right?
shaving.
The vitreous base or the vitreous beard?
No, the vitreous beard. Yeah, they actually have that little sticks that you can stop the bleeding.
Oh yeah. Oh, these. Oh, I didn't know that.
Yes.
Let me tell you the solution. Don't shave.
Yes. Yes.
Ahmed.
Yes, Barbara. Yes, please.
Just let me say that I tried tranexamic acid like last week on a patient that said, please, doctor, try it on me. I don't care whatever happened. It was almost a lost eye. And at least I can... It was bleeding like hell and it was almost blind, so we could do it and nothing happened on the retina. Nothing happened. It was not toxic. It had no toxic effect. And they use it in every organ, like the heart, in the vessels. They use it everywhere. It was my anesthesiologist who insist that I tried. It works very well in the episcleral so in the episcleral, but also I tried on the retina, and I can tell you at least that nothing happened. So sorry for intruding, but I was trying to send you messages.
Barbara, nothing in the sense
No, it was efficient. It was efficient.
Yeah, it was effective.
And
so it stopped the bleeding.
It did not have
and no toxic effect. Okay, that's good.
Exactly.
That's fantastic.
Sorry.
You've read my mind. I was really thinking about it like a few months back, and I was thinking that maybe I should try to experiment with it, maybe just for toxicity or something. But it's good to know that it's used in the heart and maybe it's used in the brain as well. I think that's
Yes.
interesting and exciting. Yes.
So do you use a microcannula to do that, or
Yes, I injected it as I would inject PFCL on anything else. It's viscous. The appearance is in between viscoelastic and PFCL, something like that, but it goes down very nicely, and so it can be controlled.
Wonderful?
Okay.
Use
Thank
like
you.
the same concentration available for DCR and everything, or was the same
I
concentration?
didn't change because, I had no idea. I knew I was taking some risk. And so I decided if I had to try, I would try it without diluting the substance. So
Yeah, maybe that's an option.
just once. I don't know if it tells you anything, but just once.
Yeah, and I think there's a point here from Dr. Perfecto from Philippines. He's saying about epinephrine infusion, which I think many of us do as well. Okay, excellent. I think, again, maybe we can have 2 points here on unmet needs, and we can then move on to case discussion. There are 2 points from Dr. Asim, our friend from Sweden, about yes, this is actually a very interesting point. This is a great point about the resight or the Zeiss lens or the indirect viewing system, and it fogs, right? And that can be annoying. It would be nice to see what others what do we do, and share that with, especially with fellows and others. And the other one is about laser with more shots coming, and we can discuss that as well. So what about lens fogging? Let's take a few points here. We'll start with the same order. Gianpaolo, what do you do about lens fogging, indirect lens fogging?
So on the resight, generally it fogs because you get breathing from underneath the drape. So what we generally do, we try to block the space between the drape and the skin. So we put a little plug there, little cotton buds to block that. And then you all are aware of an alcoholic solution that is used to sort of clean the lens. I would have more things to say about the resight, which now have come to my mind. For example, many times it's in the way when you're trying to maneuver, you have to switch hands because you actually are hitting the lens itself with one hand and the instrument. So that should be made less cumbersome if possible. And one advantage of the stick-on lenses, especially the wide field stick-on lenses, which were the mini quadraspherics, was actually that they moved with the eye, so they were less cumbersome than the resight. But yeah, that's my take.
These are great points. Again, does anyone, Walid, do you have any tip from that?
In this case, I look for the drop. It must be close to the skin and without connection with the under of the drop. The first step. After that, I can make a pad near the nose and imbibe with BBC the pad. So that's why we can remove the fog from the lens.
Okay, Mariano, anything in addition?
No, just the same. I think the key is a correct draping, and if it fails, I do cut a small patch of drape and I stick it in the side of the nose, and
yes,
generally that works.
Yeah, especially if it's under general anesthesia, right? Especially, I mean, local anesthesia. Do you do this with local anesthesia as well, or general anesthesia?
So for me, okay.
No, go ahead, please.
Go for it. Depends on the case. It's a very complicated cases. I do general anesthesia, but usually I use local anesthesia.
No, but can you
There
block
are-
the nose
the-
with local anesthesia? That's-
The fogging generally occurs with local anesthesia because for obvious reasons. General anesthesia can leak. So even if you have even if it shouldn't, but it does sometimes, and therefore you do get some fogging, but in a lesser degree than with local anesthesia. I think we all agree with that.
With draping and blocking the nose, you can actually block
Yes.
the nose with opsite. You can block the nose with
I
opsite.
think-
It's a little bit tricky when you're operating on local
أنا
anesthesia.
بتقولي علشان كنت عايزة المروحة أتخوى بيها.
There are
And
two other issues
yes, please.
that you have to mention. One of them is the distance of the lens from the eye. If you're too close, you have more fogging. So one thing you can do is elevate in case of repeated fogging despite, blocking excess of air, breathe out air to the operating field. You can still have fogging. So maybe you can elevate the microscope a little bit.
Yes.
But the other thing that you have to remember is the temperature difference between the lens
eye.
and the operating room temperature. So don't make the operating room temperature too low, because then you have more fogging. I remember being in operating rooms which were 14 degrees. That's not ideal in terms of fogging. So pay
So
attention to that.
the point you've just made is absolutely true, because if the temperature is low, the eye has a higher temperature, so that's why you get the fogging,
Right.
and that's why by moving the lens further away from the eye, then you get defogging. But
Yes.
you can sometimes moving the lens, you don't want to move the lens too far from the eye for obvious reasons. So the logical solution is not to have the temperature in the room too low. That's it. Yeah.
Yeah.
Yes, excellent. All right. Any other points from Radwan? You have something? You want to say something?
I agree with everything. Being someone who really likes the OR ropes, they're really cool because I have the gowns and I really feel hot. So sometimes we try to, you can hold the lens and warm it a little bit, like in your hand. It will fog at the beginning. And there was a poster or something about this like a few years ago. So they found like you can try to warm it and try to stay away a little bit for like the first 5 or 10 minutes. And then when you get closer and it's warm with your hand, the fogging get less and less. But the key thing is just like the leakage from above the nasal bridge. So I really stress on my training, just make sure it's really sealed well over here. And I really like the gauze and BSS idea to block any leakage. I used to use a lot of gel. It's not economic, so I may try that.
And the absolute final solution is you make the patient stop breathing.
Yeah.
Completely. That also helps with bleeding.
Yeah. Yes, it will help. So it actually serves all the unmet need. I just want to share something here from Barbara, which I use as well. Let me just share my screen quickly, and I'll show you here. This is two solutions. One solution is actually here, is described by a colleague of mine from Arkansas, and is actually using this. Can you see my screen?
Mm-hmm. Yes.
It's using a catheter, a urinary catheter, to suck the humidity. The problem is it dries the cornea, so you have to maybe use viscoat on the cornea. What I was trying to do is to use a smaller catheter just to put it near the lens, or hang it to the lens, but so far it just did not work and I gave up on this. And I think I may need to revisit this. Another option that was suggested by Barbara, which I use, and I used in the UK, and it's not toxic, is that we use this anti-fog solution, which is available in your theaters because the endoscopy people use it, and you just touch the lens. It works so well.
This is what we use routinely. Yeah.
The third option, which I'm not really sure about OR sterility, is to have a small fan like the one they use near the computers attached, and that just fans the lens and that gets rid of all the fogging. I'm not sure about sterility. I've seen that done in some theaters, but I'm not sure about like sterility and infection disease. People are gonna like this or not, but just a small fan. And I think we may have seen Mohammed Tawfiq from Egypt using that and showing it on one of the Facebook groups. All right, excellent. The other thing is there was unmet need. Is laser doing like lots of spots? This is coming, and this is coming from Alcon. I know that Alcon is working on a laser that will be coming with deliver like about 4 spots in the laser, and I think that would be a time saver.
Yes.
Okay, excellent. Maybe a quick point, and then we move on to the actually case presentations. Unless anyone has another quick discussion, but maybe a quick one for everyone. Just a quick answer. Gianpaolo, do you use the laser on like multi spots or a continuous laser in general? And do you have any? I mean, my laser doesn't look very nice. I mean, I've seen videos of laser where the laser look very beautifully rounded and nice. My laser doesn't look like that. It actually looks more embarrassing. For some reason, I cannot make it nice and rounded. So do you have any tips for that, or you don't mind? And use continuous or interrupted?
Actually, I started my career as just doing lasers because before I was granted a vitrectomy machine, sometime had to go by. So I did my lasers quite neatly, and I still like to do that. So I use
I'm talking about endolaser.
Endolaser, yes, yes. So I still like to do that. Endolaser wise, I use single spot, which I know everybody will probably smile because, but I like to know that what I'm hitting is where I'm aiming, I'm delivering. So I don't like the idea that I have to keep up with the machine because my interval is such that I have to keep moving the tip. I like to aim, shoot, aim, shoot, aim, shoot, which takes longer. But as you say, it looks nicer. And I think also you're probably getting, let's not forget that these people must retain their visual field. We're talking about diabetics, I imagine, and PRP. So we try to limit the damage which is done. And I think that putting the spots, as we've been told by the masters that used to do the lasers, you have to place them neatly, one spot apart for each one because they tend to enlarge. So there are certain rules that must be followed. And the idea of having continuous laser delivery does not allow you to really do that because there's no time to aim and to really deliver where you want to deliver.
Excellent. Okay, Walid, do you use continuous or interrupted, and how would you rate the roundness and the beautifulness of your laser out of 10?
I haven't special tips for the laser. I use a normal laser, repetitive spots. No special things with lasers. I prefer to enhance our laser to for multiple spots. Why not? It will be faster. That's all.
Thank you. And Mariano, what do you do?
In general, in diabetics, I do use single spots. I put the machine in the repeat mode, not too fast, and I go that way. Sometimes in retinal detachments, if I have for example, in a giant tear or a big tear, I sometimes use a continuous laser to create like a line. But in diabetics, I usually use regular spots.
Single spots.
And Saad, what do you do?
Yeah, no, I have to say I'm more like you, Ahmed. I'm not concerned about the shape, and I'm not actually good. And I think by the time I reach the stage of endo laser, I'd like to do it quick. And I don't necessarily agree on very confluent large spots and seeing a very white burn. I like to leave these patients with a little bit of visual field, but most of the time my laser spots don't look nice. And I agree. I'm like you, Ahmed. So.
Actually, I'm concerned. I'm trying to make them look nice, but I
stopped trying. I'm happy. Patients are fine.
I remember asking someone. He said, "You'll do it with experience." And I said, "I've been like doing it for nearly 20 years now, and I just cannot get them rounded." Farron, what do you do? Continuous or interrupted or?
Well, let me just say that when you look at the eye, where I did pan-retinal laser, it looks about as nice as I am. So it's horrible.
No, it's beautiful.
I really don't spend as much time as maybe I should on doing this. My laser spots are individual. The repeat mode on the machine, it's 0.1 second. And I learned how to move my probe accordingly. I do a lot of laser cerclage in the periphery, where this is not so much a big issue. But in a diabetic where it's pan-retinal, what I do is I make a circle around the area within which I do not want any laser spot. So in case it becomes a little automated, which it does, I don't run the risk of getting too close to the fovea.
This is the principles of that we use as laserists rather than surgeons. We always used to do this. There's a delimitation area where you want to mark off the area where you're not going to be lasering, and then you fill in from there. Yeah.
And Radwan, anything in particular? Does your laser look beautiful?
Well, I try, but I agree with everyone. Like, mainly, I'm looking for like the results. So when I look at an eye, I know that's my doing, but it's okay as long as it's flat and seeing and they're happy. I do intervals. If it's a tear or like a retinectomy, like it's a higher frequency. So I'm like, because I want it like to be more confluent scars. If it's a endo laser PRP, it's a little bit slower. Try to get it more prettier and efficient as well. Like keep the peripheral visual field. I've seen people doing continuous painting. I tried it. It's not my thing. So I went back to the interval. Yeah.
But we were talking about beauty, so let's hear Barbara.
Yes.
So thank you anyway. I'm here with you. I think that what we have to adapt to the indication. So you've all said it already. If I have to seal a retinotomy, I do a continuous laser. We can all learn how to move our hands accordingly, not to over-treat any spot. So if you have to seal it, it's continuous. If you have to do a pump photocoagulation, it's multiple spots, one spot of space in between. And it can be a unique, very fine pointed laser to treat aneurysmatic lesion. So we have the whole panel. Every option is available and we need to adapt to the indication.
That's fantastic. I think we'll move on to the cases. Before that, just
but if you allow me to say one comment, because we are speaking about instrumentations and technique. When we treat the periphery, I'm finding that it does make a difference what type of laser you're using, because in some laser you have to pull and push a button to extract the tip. And sometimes if the movement is not smooth, you really risk to damage the lens if it is there, or to damage the retina if you're not careful, especially if you are using the endo-illuminated laser without an extra light and you are depressing the sclera yourself. So we need to, I would like for the companies to have an endo-illuminated laser that allows a better view of where the tip of the laser is. Because when I'm inside with the endo-illuminated laser, sometimes I don't know where my tip is. I can see the retina, which is illuminated, but I cannot see the tip of the laser itself. So I think we are taking some risk with that maneuvers. So we could ask the companies to have better options.
Yeah, absolutely. I think that's a great point. So I think just to summarize Barbara's point, which I think is great, you have the straight laser, and then you have the curved laser, which gives you a bit of more clearance of the lens, so you can actually cross to the other side, and it's nice as well. And you have the directional laser, which you can change the direction. I think that's what Barbara was talking about. I don't like it because the problem is you may remove it and it may hit the retina. But the other problem, which I find, is that if you come out with the directional laser not fully disengaged, then the
trocar comes out as well.
So I don't like it because I need to think. So I use the curved laser or the flexi tip, which
tip, better one. Yes.
Flexi tip is very nice, goes very nicely. You can cross to the other side, more clearance from the other one. Barbara was talking about the direction, which I see it's really advantageous because you can laser under your laser probe, but the problem is you have to be very careful. All right, excellent. And the last step I just want to leave you with is that something I think many of us know, but some may not know. When you're on the laser mode on the Constellation, which we use a lot, the extrusion works. So you still be on the laser on the machine, but actually if you change the pedal and use the extrusion, it will work. And the advantage of that, if you can have illuminated laser, you can have the extrusion in one hand and drain as you are lasering, especially if you're doing a drainage retinotomy drainage and you want to laser it. So just something to be wary of. When you're on the laser, the extrusion function works on the machine. All right, well, let's,
No, that is a great point. Thanks for sharing that.
Yes, I've just heard it in one of the meetings like a few years back, and I thought actually that makes sense. It's really lovely. Okay, excellent. I think that's let's move on to cases. So we'll start with Farron, if you want to start sharing your case.
Okay, I'm trying to. Can you see the video?
Yes, sir.
Okay, so this is a young guy who has high myopia, and then he develops a retinal detachment and goes to an ophthalmologist, an anterior segment surgeon, who of course recommends, you will never guess what? Cataract surgery. The lens is clear. So they had the common sense of not agreeing, and they went around and then finally came to me with this. So it's very obvious that you need to deal with the sclera first. So this is how it looked on the operating table. The first thing you have to do, of course, is to have a view of this whole area, which means you separate the conjunctiva from whatever is underneath, and you don't know whether it's pure choroid or there is some scleral remnant here, but in this case, there was virtually no sclera left. When you open this, you have to be very careful. The eye pressure is very high. You run the risk of an expulsive choroidal hemorrhage if you rupture the choroid. So I'm using both sharp and blunt tools to separate the conjunctiva from the choroid. Eventually, I go and use viscoelastic as well, as you can see here. The reason why I don't use viscoelastic from the very beginning is because I want to control where the two tissues separate. And then you have to do it carefully at the limbus as well. Let me go a little faster in the interest of time. And so now you exposed the entire area, which of course is gigantic. You can't even measure the whole thing in one session. So then you have to put a patch there. This patch is sclera, which you have to suture onto intact sclera. So no more cutting at the edge. And it's not a side to side, but on top of suturing. I start the suturing from one side, and a couple of vicryl sutures are introduced. Again, let me go a little faster. So it's about a third, maybe 40% of the circumference of the scleral patch that is placed there. Because then comes a very important part, which is you have to shrink this choroid back into plane. And the way to do it is to use diathermy. It's a light diathermy with a flat probe. And you have to do this part of the surgery very fast. Because, and let me stop it for a second to explain. So you have to diathermize the whole area that will be under this patch. And the reason I'm saying under this patch, because this area requires a second patch. You can't have fashion from the material available for you for the graft to do it using a single piece. So when you do the diathermy, it immediately shrinks the tissue. But the problem is that because of the pressure, you have literally seconds to fashion a complete situation to suture the rest of the sclera back to the bed. Because if you don't do that, this bulging choroidal situation will recur. And you can just do another series of diathermy spots, because as the tissue shrinks, eventually you will see that the iris is dragged towards this area and you cannot do anything with that. So this part of the surgery, unlike everything else we do in vitreoretinal surgery, has to be done fast. So that makes a difference. So now that patch is there, and then you have to implant a Unmet valve to control the pressure, which is crucial for this whole area not to have the entire process repeated. So you place that, and then once that is in place, then you go back and repeat the patching in the remaining area. The anterior chamber is extremely shallow, so you have to go through the iris into the anterior chamber with the tube. And for that, you need a second instrument, as you saw there. So now the patch is complete, and the eye now is more than 10 years after the surgery. And although you can see the blue, but it's not, it doesn't have a rupture risk anymore. So, any questions?
That was fantastic.
I have a comment.
No, I'm sorry. One more comment. So obviously, once this was in place, I waited about 10 days, if I remember correctly, to go and do the vitrectomy part to fix the retina. It's a highly myopic eye, so the vision was very poor to begin with, and it remained poor, but the retina is attached, and that little vision is still there, and the pressure is still fine.
I have two questions.
Mm-hmm.
So one is, I had cases like this where I placed the sclera, and in all of them, I have seen retraction of the sclera in time, as I saw also in your case. Do you think there's a way that we can use to prevent retraction and the new exposure of the choroid in a second time? And my second question is, since this type of eye has every type of risk of choroidal detachment in the postoperative time, because it's high myopic and because of what you did, the Unmet valve and all the other procedures, how do you prevent significant hypotony and choroidals?
Well, I had
Do
neither.
you inject
I had neither of these complications, so I don't know what I would do to prevent it, other than hope it will not. I have no idea. But again, I did not have those complications. And even though, as you saw, there is some blueness there, when you look at the eye under the slit lamp, there is still sclera there, so it's not gone, and there is no bulging. And because the pressure is normal, which is a very important point here, I think the risk of a second event is low. It may happen, and in that case, we may use some different material, but the only thing I had available was sclera.
I have 2 comments, if I may.
Of course.
Right. So I've had several cases like this, and I wanted to just point out first what you did. You performed a vitrectomy with the Hammett valve in place, which again is something that not everybody feels comfortable with, but that it just goes to prove that you can do any maneuver that you need to do, even with the valve in place, because the valve will respond very nicely to this. So I think you made a good point here. The second point I want to make is the use of the sclera. Now, obviously, you only had the sclera. We are not always allowed to use sclera because it especially since the mad cow disease and everything else, we've had problems with tissues of the sort. But it also seems that the human sclera can be more antigenic, so that we generally use tutopatch, which for some reason seems to be give less reaction, so it is less readily reabsorbed. Whereas the cases I did with human sclera, I found that the reabsorption rate was higher, and also it's easier to cut and to maneuver, to handle, because the sclera is a bit more rigid, whereas tutopatch is very, very pliable, so you can cut it better, you can suture it better. And only that comment.
Yeah. Okay. Again, I had no option
Yes.
back then, but for the future, I think we are in a better situation now than back then to have a material selection.
Okay, I think we have to move for the sake of time. So our next presentation will be by Jim Paolo.
If I can get it to you, let's see.
Yes.
So
yeah, we need like 10 hours
is that
to finish all discussion, and that's the problem really of
can you see my screen?
Yes.
So right, so this is a problem which doesn't occur, fortunately, very, very often. We're talking about macular folds, retinal folds in general, and these are complications that occur with any sort of retinal detachment repair, if you're using buckles or pneumatic retinopexy or vitrectomy. And now, how do I go forward with this? Oh, just pressing on it. Okay, easy. So actually, the importance of the folds are related to where they form, and I think we can discuss on this later. But obviously, if the folds are not within the macular area, I think you can just leave them. If they are within the macular area, and if they are very, very severe, obviously intervention must be almost immediate. Okay. And this is a mechanism with which they form. My artist qualities are very poor, so I try to make the point here. If you have a detachment, you put a bubble in, and the gas sort of makes the subretinal fluid reabsorb. You can actually have the retina which is trapped and stretched, and it's redundant, and therefore it will form a fold. There's a very good article on this if anybody's interested. It just goes to explain how these how these retinal folds do form. And here is an animation which is a bit clearer. If you see, if you're putting in the perfluorocarbon, you actually get the segregation of subretinal fluid here in the periphery, and therefore when you do you apply the laser and then you do remove the perfluorocarbon, you can have that the that fluid and that redundant retina simply comes forward and to the center of the eye and forms the fold. And this is a case presentation. Sorry, this is the so this is a case presentation. I fortunately I only had a couple of these cases. Essentially, the patient did not do what he was told to do. It's easy to blame the patient, but in this case, it was his fault. He did not position. He did nothing of what he was told, and then he simply showed up in the post-op period with a condition which was which was, for the sake of time, I just want to go faster, which was this. So you'd see that the retinal fold here is significant. It's across the macula, and obviously I tried, it was my first case, so I tried whatever came to my mind to release these folds, which included the ILM peeling first, which may not be necessary. This is a point of discussion. But more importantly, I knew that I had to release the fibrin bridges which had formed underneath the retina. So I redetached the retina and gently massaged it to allow it to go back into place. And to do that, I also used perfluorocarbon, which helped me redistribute the weight of the pressure that I was applying on the retina more evenly, so that I avoided unnecessary traction just in one particular part of the retina, and therefore with the risk of iatrogenic damage. And this is what it looked like at the end. Most of the folds were gone, and the patient was not happy because his vision was not good. But from an anatomical point of view, we had a very good result. And that's it.
Gianpaolo, thanks. That's fantastic. I think it's a great point, and I think the animation you used from and the paper you cited is great. And I think
yes,
it's one of those things that I think it's best not to use PFCL routinely. But again, I think we can have a couple of points of discussion about how to prevent falls in general, just to stick to the point. Any discussion from the panel here about how to prevent falls? If you just have like short points.
Can I say a few points?
Please, Saad.
First of all, it's a great case, very tough thing to do. Luckily, it's very rare, and I think you stated at the beginning that not all folds need to be corrected, and I agree with this. I think preventing it is probably the best. Trying to remove as much subretinal fluid during the primary surgery is also important. Positioning the patient also plays a factor, because if the patient, as you said, does not position right, and the bubble itself does not press on the retina, then by the time the RPE pumps start working and removing the small amount of subretinal fluid, and the patient is not positioning in the right face down position, then this is when the fold might happen. If you leave a lot of subretinal fluid, also there's a risk. So I think taking your time in removing the subretinal fluid is crucial in preventing the formation of macular fold. Thank you.
I have two comments. Sorry, go ahead.
No, the point is exactly positioning post-operatively is very important, and I did run through the slides. I think you saw one of the slides was the idea of having first position the patient on one side, so that the temporal side would be on the pillow, and that allows for drainage of the fluid and reabsorption of the fluid through the RPE pump, and then it's face down. Excuse me, it's face down for a few hours. The patient did nothing, none of this. So yeah.
Fantastic.
Can I just, two very quick comments. First, if you have to do surgery, and I agree, if it's not through the fovea, you can leave it. But if you do, you have to do it as soon as possible, because the longer the wait, the more difficult it is to get rid of it. The second
Exactly.
point is we all see retinal detachment everywhere, and you would think it's easy for the retina to get read, but it's not. So when you redetach the retina yourself, you have to struggle to get the point where you want the retina to read. I don't know what the hell this is.
Interference, yeah.
It's okay.
Yeah.
I'm stopping it as it comes.
Yeah. So it may not detach where you want it to redetach. It may more easily detach somewhere else. So you have to, be aware of that.
You made a very, very good point. And unfortunately, what the video shows is what happens inside the eye. It doesn't show what happens, what the surgeon is doing. So nobody says this. If you are detaching the retina, it's very difficult to redetach it. And actually, you must use what I use is an infusion pump with low settings, because otherwise, if you're trying to do it manually, you never get it done. So, and the control is not there. So you need an infusion pump that allows you to redetach very gently that retina. But again, it's not an easy thing to do. It can go horribly wrong. Yeah.
I think these are a great point. And to just summarize, the problem is too much fluid, effect of gravity. PFCL was not found to decrease the risk of retinal folds. Actually, it may increase the risk. Even drainage retinotomy does not decrease the risk. Maybe draining from the break is better. But I think it's a big discussion, and no one knows which position is best for this, at least so far. So,
Do we have time
Radwan,
for
do you want to say
quick?
something quickly?
Just quickly, usually if the detachment goes inferior to the fovea or the macula, I'm less worried because even if they will have a fold, it will be far away. Some people who were saying if there is some residual fluid, no matter what, at the fovea, they will leave some fluid within, like they will do the like fluid air exchange, but they will leave some fluid, especially with peripheral breaks, and they will put their gas bubble and they will position the patient laying on their back. So the gas bubble is up and closing the brakes, and they're avoiding folds at the fovea. That's just a thought.
Yeah, this is a great point, which Stratos Gotsaridis makes time and over again. He leaves a bit of fluid at the back of the eye, and he thinks that his results are good with this procedure. Yeah.
Yeah, Stratus puts the patients on the face down position. He says the Muslim prayers position. I put the patient face up, and others do face up as well. So I think this where controversy is there. Is it face up or
but you both leave it wet.
Yes, we both leave it wet.
Yeah.
So I think it's a good point. No answers, but we know like at least some theories why it happens.
Yeah.
Okay, well, I have to keep moving, unfortunately. Well, let's move on to another topic. And Mariano, if you want to share your topic.
Yes.
Okay. As you share, there's a quick question here from Dr. Dimitri Tsouris about drainage retinotomy at the end after fixing the fold. I think that's what you did, Jim Paolo. Did you do a drainage retinotomy outside after removing the fold, or you did not?
No.
Because it was like a peripheral. You pushed every.
I allowed the gas to do the rest. Yeah. No.
And the redundancy was pushed more peripheral, right?
It was basically just went. It was a fresh case, so I think the retina was still very elastic. So just removing those fibrin bridges underneath the retina allowed the retina to be freely just go back into its normal position.
Right. Okay, back to you, Mariano.
Thank you, Ahmed. Well, I'm going to share with you a case of a macular hole RD. Can you hear me?
Yeah, you can hear me.
It's a case of a macular hole RD, which sometimes are difficult to deal with. And I will highlight some points that I think that are important. This patient had a very, very huge hole, more than 1,000 microns. I try to use in almost in every RD case, I use triamcinolone, but I think especially in these cases in myopic eyes, highly myopic eyes, I think it's really important, and it's I think it's a key point here because it's very common to find these remnants of the hyaloid stick to the retina that we need to remove, not only because of to get the retina to reattach, but also to allow a good staining of the ILM if we want to do the flap. The second thing is that in general we try to address these patients doing an ILM flap, and as the retina is detached and it's more difficult, we do the peeling and the flap and the TFO, and in general it's difficult to this is what it usually happens to me. The ILM starts to roll over itself, so it's difficult to create a flap. So many times I end up doing this. What you will see there is like petals over the hole, and trying to create like a plug over the hole. Especially when the hole is big, I end up with a fluid air exchange, and I usually leave these eyes with a gas. You see there that it's a remaining remaining fluid on the bottom of the eye, and this is the picture a couple of months after the surgery. You see that the hole is, I think it's not closed, it's like plugged, and it's some remnants of ILM plugging the hole. Thank you.
That's beautiful, Mariano. Mariano had a beautiful paper in Retina on concurrent macular holes with retinal attachment in non-myopic patients, which is a situation that happens and might be difficult to close. So yeah, Mariano, that's beautiful. Any comments about, I think PFCL is nice. I know it's, I think that's one of the advantage of the PFCL. It makes it like roll, but then it sticks and it's not like flying up. If you try the peel without, or the flap without PFCL, it keeps like flying up, and sometimes difficult to put on the retina unless you put some viscoat on it. So any comments? We can have one comment and then we can move on to the next case.
Can I have I've got actually a comment and a question. First comment, I think that's a great case, Mariano. You've handled it very well, and I think you probably want to wait a little bit on this patient. You might see a little bit of regeneration, I think, with time. Did the vision improve, or do you see any improvement in vision?
Yes, the vision improved to 20/200.
Oh, that's great. I mean, these are tough cases, I know. One thing I wanted to ask you, I noticed you said at the beginning you like to use triamcinolone, and I also do like to use triamcinolone. What would you do if some of that triamcinolone got under the fovea through the hole? Would you go up draining it, or would you leave it? Or
I try to aspirate gently with a soft tip cannula, but if some triamcinolone goes far away from the place where I can suck it, I just leave it. I do not make maneuvers to go under the retina or something like that.
In such cases, I think using PFC was a great tip. But in such cases with such a large hole, would you do air fluid exchange and drain through the hole and then do the ILM? Would you think that would be a possibility?
I did that. I did the fluid air exchange. I drained through the hole, and then I stained and I put the PFO. And after that, I did the peeling. Yes.
Oh, that's a tough case. Congratulations.
Thank you.
Sad, to your point, there was a study that was published in Eye many years back. They found that there was no difference in closure rate if you have triamcinolone in the bed of the hole.
Sometimes. Yes, I have a question. Mariano.
Yes.
When we inject blue treatment, Vitreoretinal blue. You inject on air or painting under PFO?
I usually use brilliant blue. I do not use trypan blue, but in this case, I did it under air. But you can also do it under PFO. You can like use there's a I don't remember the name. It's like a rubber balloon where you put the staining and you push a little bit and you can stain the retina under PFO. It works very well.
It's the Eckerd. It's the Eckerd balloon. Eckerd.
I think
I
yes,
think
or the
Eckerd developed that.
Holocan balloon. Yes.
Or yeah.
What we do if there is some brilliant blue pass through and color the under of the retina, so it will be sometimes difficult to peel the membrane when we have some. That's why I use usually brilliant peel under PFO. Sometimes blue pass through the hole and color the retina. So what we do in this case, it's very difficult case, and when we have blue under the retina, you understand?
Okay. Yes. I understand. Yes.
Might be a good option, in like difficult holes, like myopic holes. So that's to close the hole with PFO. That's a good point. I think for the sake of time, and we have to keep moving. So our next speaker is Dr. Saad from Saudi Arabia. Dr. Saad, we're
Thank you. Thank you very much. Thank you, Ahmed. Let me share with you this case. I don't seem to be able to share. Would you ask the next speaker until I see what can I do?
All right. Our next speaker is Radwan. Radwan, do you wanna go ahead?
Sure. I'm happy to. Okay, so I'll be efficient. So I'll try to. Okay, share. Can everybody see my screen?
Yes.
Okay. So this is this was like a 2-minute video, but I'll just go to that second case. So I had a case that, so usually we have a lot of trauma cases, and many of those patients have like opaque cornea, and they have some retinal detachment repaired somewhere before they come referred to us. And then they were referred to our place to have cornea transplant and oil removal. So because of the logistics, and I really don't know that they come without any records with them. So I started doing exploratory endoscopic retina surgery where I tell patients, I will go with the endoscope, have a look at the back first. If everything is good, we'll remove the oil, and then you can go ahead with your cornea transplant laterwards. So this patient was referred came from 4 hours away. He was told like everything is good, go ahead and have your oil removed. And I'm looking here with the endoscope. This is the best quality, by the way. This is a 23 gauge endoscope. We can see like he has like I see a shallow retinal detachment with subretinal traction bands. So but I think it was so shallow, that's why they couldn't detect it on the B scan before surgery. So this case turned on, instead of just oil remover and maybe laser, to the retinal detachment repair. So what we did is the eye was filled with fluid, with oil here. So I made a retinotomy, and I go with a 23 gauge forceps. Thankfully, it was away from the macula. So I tried to peel, and I'm peeling the subretinal membranes under oil. Of course, marking sometimes. So, and lasering to prevent bleeding and on the cautery as well. So this was the traction membranes, and it was too thick to remove, to pull through the trocar cannula. I used the 23 gauge trocar cannula, but this was too big. So I ended up eating it with the vitrector here, under oil. Then we went back again with for the second half, also looking carefully everywhere, making sure I'm not causing a detachment at the periphery. And thankfully it went out really well. We ended up doing some laser, and then I told him, like, I kept the oil in. This is the eye, how it looked like at the end. Like few months later, the retina was flat, and we end up removing the oil, and I send him for the cornea transplant. So that's the case. I found this case really, like, this is why I like using the endoscopes and using new technology. It helped facilitate. If I go out for a combo case with the cornea, patient will have a new cornea, and then it will fail because of the oil still there, and then they will have, they will need another cornea. So
Radwan, this is great. And Radwan was very kind to give us a TOCA, I think a year back, and that really made us use the endoscope more. We use it now in the same indication. Also, it's very beautiful to look at the ciliary body area, close cycle diastasis clefts. I think otherwise it's the problem is you don't get binocular view, but I think it really has good advantages in exploration. And as Radwan mentioned, to avoid the use of oil with grafts. I think that's a very good point. And also like the ciliary body area, it's a beautiful view. Can we have any comments?
Before we move the picture, I want to make a comment. It's too
sorry.
late.
Yeah.
Yeah, that's okay. I have two comments. One is if this cornea had been sutured properly, which it was not, obviously, this eye would not have needed a transplant. You know, the scar is not in the visual axis. If you do a good job with full thickness, proper length, properly spaced sutures, this would be a relatively minor scar not interfering with vision. The second comment is the retina. So it's not only for those who do endoscopic removal of subretinal strands, but anybody who does that. The vast majority of the cases, as in this eye as well, you can do what you did beautifully. You grab that scar tissue and drag it one direction, then the other, and take it out, period. But in a few cases, at the end point, which you may not see when you do the pulling, the strand is so attached to the retina that it can drag retina with it rather than separate. So make sure every time you do this, you look to the two ends of a long strand to be sure that it is coming without dragging retina with it.
That's an excellent point. Thank you.
Yeah, that's a great point. Saad, are you ready?
There is a share screen green bottom at the end, the buttons. Yeah.
Excellent.
Sorry, can you see my screen?
Yes.
Okay, great. So I'm going to share with you, this is a very unfortunate, uncommon complication. But again, one of the unmet needs in ophthalmology. And I've always been uncomfortable with the concept of following the EVS study where you would inject patients like this. This is a patient that has come to see one of our colleagues post cataract surgery, post extra cap, as you can see, the sutures, and they injected him, I think, once, and then they thought he's not improving, and they were considering evisceration. At this stage, we saw the patient, and we thought we would probably consider a surgery, and we took him for vitrectomy, and I think it must have been 24 hours after the injection and after the presentation. So I think you can see how bad is the case, and the cornea is melting on the temporal side. But what you want to do really is you want to clear the anterior chamber first to see if you have any view. I was lucky. This is a case where I used actually 20K 25 gauge vitrectomy, and we used the Ingenuity. And I think the visualization was very much something that helped us. And in my opinion, if it was not for going for an early vitrectomy, in cases like this, you would probably could have lost the eye. You can see now in a second, once we have stabilized the corneal gaping wound, we went into vitrectomy. Now, the idea is to go for a complete vitrectomy, not just a core vitrectomy. In this case, because the view was very much limited, I elected to do a safe vitrectomy. So we went into a core vitrectomy. Initially, I used some air to see if I can get a better samples, and then tried as much as I can very slowly to take using the 20K, which was, I think, very, very helpful. If the visualization allowed, I would have probably gone deeper and gone to the extent of inducing a PVD, trying. I've got actually other cases, but for the interest of time, I'm showing this case. So this is how we started. This is at the end of the surgery. We injected antibiotics. 2 weeks later, the patient actually vision improved into 20/50. So I don't think injections would have done this. Honestly, I think endophthalmitis is a surgical disease. The only reason I wouldn't go for surgery is if I don't have access or I can't access the OR, I would do the injections. But I think, this is a surgical disease. You want to go as soon as you see the patient. Thank you.
Can I quickly comment on this?
Yeah, Saad, this is great. You would not have best audience than the ones we have here. You have Farah,
I know.
here.
This is why I picked this topic, by the way.
So can I just say, can I just say this was very, very good surgery. And again, recently we read some papers about removing eyes. We should not be removing eyes, even with no light perception. I'm sure you all read the latest paper on this. And light perception, even light perception, no light perception, can be very misleading. So well done, because you saved the patient's eye. He has some vision left, and you did what I think is the right thing to do. And I'm sure Ferenc will have further comments on this. May I just say, this is not early vitrectomy. You did what you had to do, but someone before you did not. So they should have done early vitrectomy as soon as they saw that the situation was deteriorating as it was. Ferenc?
Absolutely. Yes, absolutely. We have been fighting the EVS ever since it came out. So it indeed, as you said, you have to do early vitrectomy. Early in your case meant as early as you see the patient. And I fully agree, endophthalmitis is a surgical indication, not an injection indication. The earlier you do the surgery, it's not only better functional prognosis, but also much easier and less risky surgery. You also did an excellent job saying you want to do a complete vitrectomy, but it has to be in proportion to visibility.
Safety.
And visibility is poor. It means safety drops. You can't go on because you don't know what you're doing. The only thing I want to mention, and I don't know if you did it or not, but the first thing I do in this case is scrape the epithelium of the cornea, because many times that alone improves visibility tremendously during surgery. So again, I'm not talking about your case. I'm just saying to everybody who does this surgery, don't skip that step, because it will help you see better.
Yes, you basically go down. You basically go down in layers. So each layer you try to clear as you get to the bottom. But that
we have to
excellent.
scrape the epithelium in this case, and I cannot agree better. And thank you, Ahmed, for this panel, because every time I present cases of endophthalmitis, one or two comes up and says that, you know, all the studies have shown there is no difference between injection and surgery, and I strongly disagree with this. I have had patients with endophthalmitis who regain 20/20 vision, and I've never seen a patient with injections who regain vision. Thank you.
Yeah,
Sad.
I
Yeah,
agree.
sorry.
We can use also, we can feel the interchamber with viscoelastic, and that's why we can decrease the inflammation and the cells in the interchamber, and that we can with these tips increase the visualization.
No, I totally agree with you. And I think clearing the anterior chamber is an important step, especially, I don't know if you've noticed, you see, you have to take these fibrin membranes. If you don't,
Absolutely.
then your visualization is very bad.
We can add viscoelastic.
Yeah, certainly. I don't routinely do this because I'm worried about the endothelium, and but I agree with scraping the epithelium. It does make a major difference in the visualization.
Absolutely.
Most of the time, if you clean the anterior chamber, you do like an AC wash, and you remove the fibrin. Most of the time, your visualization improves significantly in these cases. Now, in this specific case, unfortunately, we had the melting of the cornea, which complicated the matter.
So let me add two very quick comments. One, the EVS itself showed, and your case shows it too, some vitrectomy is better than no vitrectomy. Complete vitrectomy is better than some vitrectomy. So that's number one. Number two, if you do this and visualization improves, you can go back and repeat the surgery, in which case you will be able to complete the complete lens.
Yes, absolutely.
I think this is really fantastic. Walid, I'm sorry, we'll have to move on with the. Well, sorry for that, because of the time. I want to give you a time to present as well. So Saad, this is great.
Ahmed, thank you. Can I have to apologize. I have another meeting that I have to attend at 6:30. So
Sure. No, I was gonna say
thank you very much. I really enjoyed the presentation. See you soon.
Yes. Thank you. I must apologize as well. I have a plane that's leaving, so I must go. Thank you so much. Thank you, everyone.
I guess
Thank
we're
you so
taking
much.
the same taxi then.
We'll see you in Budapest.
Yes.
We'll see you in Budapest.
That's right. Take care.
November 14th to November 17th. Everybody there, please.
I am coming.
Okay.
I am
Okay,
coming.
great.
Take
Great. Thank you. Okay. Thank you, Hamid. Thank you.
Walid, you want to get your case? Walid, you're muted. So okay.
So for my case, it will be for.
Yeah, if you can start sharing, and this would be great. As you get your case, there was a very quick question from Dr. Muhammad Audallah about how to gauge diasthermy to avoid perforations through the choroid. I think that's a very difficult one, that you have to be gentle. And I think, you know, when things are standing up, you can do a diasthermy, which is safer.
You can pass
when
to another one, Ahmed, to another speakers. There is another speaker.
Sure, yeah. No, there's only me, but I don't think, yeah. If you have your case ready, go ahead. I don't want to take your time.
Okay.
Yeah.
I'm looking for.
I'll leave the time for you.
So
we can see your screen.
You can see?
Yes.
Okay.
Yes.
Yes. Okay.
Yes.
So I will talk about fluovidrectomy. It's as I am in training center, I have to facilitate skills transfer, especially with my fellow VR surgeon. So that's why I use this kind of dyeing to facilitate transfer. So it's one eye patient combined phaco-vitrectomy for hematologic retinal detachment. We performed partial vitrectomy. We decided to color the vitreous with a pure fluorescein. Here we have to be careful not to touch the retina because we said we have a concentration dye and can mask the retina when
Walid, sorry,
what
I'm trying to switch off.
should I? There is a lot of.
Yeah, I'm trying to switch off. Yeah, we're trying to switch off.
Okay, can I go?
Please.
You. Okay. Ahmed,
Carry
you
on,
see
please.
screen, you know? So here, Ahmed.
Yes, I can hear you. We can hear you. Go ahead.
So here we are moving to the peripheral. As we can see, the dye stain well the vitreous, and in this we can avoid the retina touch. Now we move to the peripheral retina. We can easily identify the cortex vitreous. Continue without worrying about touching the retina. Here, a wild wind, it's amazing when we aspirate the subretinal fluid. After injection PFO, we can switch the pipe light to the blue to enhance the contrast between vitreous and retina. That can help us to complete vitrectomy and at the basis and look for other retinal bricks. External indentation can be useful in these situations. Before injecting the silicone oil, we can make a fluid exchange through the tear, and we perform laser retinopexy. And as we see here, we find another bricks, especially with the aid of the dyeing. We perform vitrectomy around the tears, the big one. So it helps follow to be careful and to be careful with the retina and to separate vitreous from the retina, and it enhances visualization of the vitreous. So now we complete the vitrectomy at the basis. Repeated spots of laser retinopexy around both bricks. We filled the retina, and thank you for watching. So thank you.
Wally, thank you so much. This is very great. It's a very interesting concept. You can also give the fluorescein intravenous. Some people try that as well, to give it like intravenous.
Yes, they tried this kind of, but when we put directly in the vitreous, now I use at 1/10 concentration. It's useful now, and we can enhance the contrast between the retina and vitreous, and can easy for the fellow who begin the surgery. It will be easy for skills transfer, surgical skills transfer. It's my main concern now is to transfer VR surgery. So I look for tools to facilitate this stuff.
Fantastic. Speaking about that, we have Hudson here from Brazil. Hudson is, is the founder of Retinosum, which again is mainly focusing on the same thing. Hudson, do you have any comment on fluorescein use?
Great cases. I've been following here. I was at the Retina World Congress meeting at the same time. We just finished. And interesting that we had this meeting on fluorescent angiography and vitrectomy like 4 or 5 months ago, and it went very well. Unfortunately, I do not have much experience on FA fluoroscopic vitrectomy, but I know it's a good tool. And the thing is that we need more of the filters to get the best visualization systems. And my question is, what system you use for doing this surgery? I mean, Genuity or whatever else?
So now I have a 3D system of Zeiss Artivo 800, and I switch the filter of the camera, or I switch the color of the pipe light of my machine, Ortli OS4. So with OS4, we can choose the color what we need. So we enhance the blue color, so that enhance the flow in the cavity when they stained the vitreous.
Yeah, it's good because the vitreous seems to be a yellowish or orange, and that would make the surgery a lot easier.
It seems a Hulk word, everything in green.
Yeah, congratulations! I like the what you did.
Yes, and it facilitates the skills transfer, as we said in the first. It's my target. For a good surgeon, is not very useful to inject, and it's clear to done vitrectomy quickly. But for the beginners, I think it will be helpful for them. What you think about that?
I like doing the vitrectomy, but I myself, I do not usually use stains for the vitreous. I like staining the ILM with red and blue. I like staining, the zero capsule for cataracts with treatment blue, but not for vitreous, because I prefer to do core vitrectomy. And after the main vitrectomy, I like using the macular lens, so I see the vitreous very well. So I don't use much vitreous colorations, and actually we can change with the Ingenuity systems the filters to get a better view of everything, and including black and white. Sometimes it gets really cool, yes. But I don't have the system yet for the fluoroscopy thing, and I think would be very applicable for especially new vessels in diabetic retinopathy. This helps a lot, so that you see where these ischemic areas are, and we are carrying on development on that, on imaging, and we'll soon be doing that. But congratulations, I loved your surgery.
It's a beautiful case.
Great, fantastic. I can show quickly something to maybe make Radwan happy as well as the endoscope, just very quickly, and then we can finalize. This is actually a case of a patient with a cyclodialysis cleft, and there's actually a twist in this case, which is nice. I hope you can see my screen here. This is a patient with a very small cleft, and we did a cryo, but it didn't work, and we'll show you now why it did not work. So here, this is on the 3D, and that's what we do is we connect. You'll see now the endoscope on the 3D, and this is the direct gonio lens, and here, you see here the dialysis, the area of the dialysis here. I'll show it to you, and you'll see it in another one. And this is the one that we did actually cried, and we thought it just did not work. The cry was not efficient. We actually, although it was a small area. So here, this is just a way of suturing, just to make life easy. You put trocars. You can do it with needles as well, but I just find this way easier to put trocars. And then Gore-Tex suture them, and you bury them. And then we thought we're done, but the thing is, there was actually, as you're gonna see in a minute with the endoscope, there was another one. This is the here with the endoscope. Here, this is the dialysis that the small one is the one that we sutured, and that was cried before. So the small one here, and you can see it here on the endoscope. And then looking around, This is here the serial body, and this is the suture here. We're just looking at the suture there. You can see it. And then looking around here, we found why it did not work, because there's another one. I'm sorry, I'm trying to get a better view. There's another one. Here. No, this is the one. Oh, here. It is here. There's another cyclodialysis that we missed. And I think we missed because we depended on the gonioscopy that we did, but the eye was hypotenuse. So I think one method is really, when you do the gonioscopy, make sure that you fill the eye with viscoelastic intraoperative, because we missed another cyclodialysis that was up there. As you can see, this is not, the endoscope is pointing to another area. So that's why it did not work. So here again, the same thing. We're just marking on the outside the areas, and we're just looking at it. That's another area, because I was thinking, is this the area we closed? That's another area. So again, we're going to use the same technique, and we're just looking at it again, or trying to brag about the endoscope since we're using it. And then here we use the same technique. And then here, passing them. And then here you can see that this one here, and these are the sutures there. And then closure. So it really was fantastic to, again, listen to Radwan's and see his passion to the endoscope. And then I decided to revisit the endoscope, because initially I tried with the 23, I didn't like it, but then I use it now as the 19 gauge, and you get good view. So again, just something to go with that. If anyone has any, Radwan.
No, congratulations. I'm so happy. Like, I'm seeing this. Great work, Ahmed. And yeah, it's very helpful. And I like that you have a really great view and a great image. You're connecting the endoscope with your viewing system, right? Yeah, no, it's
I'm
beautiful
connecting on the
work.
3D. It's still a monocular view, but the thing is, I'm looking all straight. I'm not looking to the side for the endoscope, and I'm able to record as well, which is nice.
No, wonderful job, wonderful job. It's beautiful, and yeah, and like it made me happy. Let's put it this way.
That's great. It was great teaching. All right. Well, I think we're coming to the end. Any concluding remarks? I mean, if we can have a conclusion remark from everyone, we can start with Ferrin.
Yeah, I think
Ferrin, anything you want to say?
a lot of useful clinical pearls that somebody watching the videos and hearing the discussions can take home and apply in their clinical practice. And I think that's the most useful thing about the webinar. So congratulations to all of you. They were really great points.
Do you have any, do you want to just, again, a conclusion remark from your side? Okay, I think all right, Mariano.
Oh, great session, Ahmed. Thanks a lot. I learned a lot. I think everybody will keep some pearls from this session. So thank you all. Thanks a lot. Thanks for the invitation. It was a pleasure.
Oh, thank you so much. And again, I think we're okay. I'm really very grateful, and very grateful for your time. Walid, yes. So you're back again.
Invitation. It was an amazing session, and we learned a lot. And it's a pleasure to meet a great surgeon over the world, Argentina, US, or Europe, I think. It's great. Thank you. Thank you.
All right, excellent. Well, thank you so much. Again, it's a pleasure being here, and thank you so much for all our panelists. Great discussion. I've also learned heaps, and again, we're hoping with EVRS, we're going to be repeating these sessions and more to come. Thank you so much, everyone. I appreciate your time, and stay safe. Thank you.
Thank you so much.
See you, Ahmed. See you, everybody.
Thank you.
And
Great to
thank you so much.
participate.
Thank you, Hudson.
Bye. You all.
Bye.
Thanks.
Bye. Bye.